Hello all. Today we will go over part 2 of Chapter 12, Psychological Disorders. In this video clip, we will continue to discuss various psychological disorders, including mood disorders, eating disorders, schizophrenia, and personality disorders. And last, we will discuss about suicide and what to do when someone might be showing signs of suicide. Most people experience a range of emotions over the course of a day or several days, ranging from mild sadness to normal emotions to mild elation. However, a person with a mood disorder experiences emotions that are extreme and, as a result, very rare and severely disturbed. One common mood disorder is called major depressive disorder, or MDD. MDD involves major depressive episodes or characteristics which may include thoughts of death or suicide for at least 2 weeks, and this is the most commonly diagnosed among the mood disorders. Typically, when an individual says depression or depressive disorder, they are referring to MDD or symptoms of MDD. So, how can we explain a cause of mood disorders, specifically MDD, using a behavioral perspective? Towards the end of the chapter on learning, we discussed about a concept called learned helplessness. Do you remember what it was? If not, does this figure remind you of the concept? So basically, at first, the dog was placed in a box that looks like this, but the hurdle you see in the middle was closed. And when the dog hears a sound coming from the speaker, that was an indication that there will be a shock coming from the floor. Obviously, the hurdle was closed, so there was no way for the dog to escape the shock. After repeating this several times, then they opened the hurdle, which would allow the dog to jump over to escape from the shock, just like in this picture. However, among dogs who learned that the shocks are not escapable, these dogs just stood there without trying to escape. So how does this relate to depression? So people with depression may have learned to be helpless in the past. And although from the perspective among people without depression, they might think, oh, why don't you just jump over and avoid the shock? But that may seem impossible for an individual with depression, no matter how simple it may sound. Again, due to their past learned helplessness. So according to this perspective, it becomes critical to unlearn the helplessness, which we will discuss about it in the next chapter on therapies. How do you think cognitive theories would explain major depressive disorder? As we discussed explaining anxiety-related disorder using the cognitive approach in part 1 of the video, cognitive approach emphasizes the illogical and irrational thought processes. So this would be consistent even when explaining the cause of MDD or anxiety-related disorders. And there are certain attributional styles that are known to be related to depression. So say that an individual was rejected by another person. If this individual said that this is a temporary setback, everything else in my life is okay, and this was not my fault, then this person is less likely to experience symptoms of depression. So this is an example of optimistic attributional style. But when an individual say that this pattern of rejection is going to last for a long time, this failure is going to ruin me, and I am the one to be blamed, then these types of attributional style would strongly be related to depression. So how we view or think about the event is going to play a major role in experiencing symptoms of depression. In a category of mood disorders, there are other diagnoses than MDD, and bipolar disorder is one of them. Bipolar disorder involves extreme mood swings that include one or more episodes of mania. Here, notice the word extreme. I often encounter people saying that, oh, so and so definitely has bipolar. But to actually meet the criteria, the mood swings need to be extreme. And so it is not just being sad in the morning, but being really happy in the afternoon. Examples of mania are when an individual feels on top of the world, have tremendous energy, might sleep very little, if at all, engage in impulsive behaviors like spending their savings on a foolish businesses or engaging in multiple sexual activities with various people. Or people may even experience psychotic symptoms like having hallucinations or delusional thoughts. In bipolar disorder, there are actually multiple types, and here we will discuss two of them, bipolar 1 and bipolar 2. The main differences between these two disorders is that the manic episodes we just discussed are extreme in bipolar 1, but are less extreme in bipolar 2, which is often called as hypomania. Although psychotic symptoms may be included in mania, in hypomania, psychotic symptoms are usually not included. And the cycle of depressive and manic episodes is usually separated by 6 months to a year, although there are rapid cycles. But notice that an individual can have a phase of normal emotions, as you can see in this scale. And this can be very tricky in treating bipolar disorder because they assume that they are getting better when they are in the phase of normal emotions or even starting to experience some manic episode because they do feel energetic and good. And unfortunately, these events can hinder treatment of bipolar disorder. And a lot of times they might stop coming to counseling. Next, we will discuss about eating disorders, which again have several different types. Anorexia nervosa or anorexia involves the relentless pursuit of thinness, such as through starvation, and as a result, the body weight is significantly low, or less than minimally expected, usually about 15% or more of ideal body weight. And note that anorexia can be fatal. Anorexia nervosa has the highest mortality or death rate of any mental or psychological disorders. Another type of eating disorder is bulimia nervosa or bulimia. Bulimia involves a binge and purge eating pattern to avoid weight gain. So in other words, an individual would engage in self-induced vomiting or starvation after binge eating. Therefore, the class with bulimia nervosa are at normal weight or above. So the difference between anorexia and bulimia is that anorexia involves significant weight loss, whereas bulimia does not. So it is difficult to see whether an individual has bulimia or not, and sometimes the first person to find bulimia may be a dentist. So why? Because chronic purging and the resulting presence of the acid in the mouth can produce many dental conditions, and symptoms such as erosion of teeth are often found by a dentist. Another type of eating disorder is the binge eating disorder. So this is a relatively new diagnosis which was formally recognized in the DSM-5. So binge eating disorder is similar to bulimia, but without the purging. And it is also known to be the most common eating disorder in the United States. And people who struggle with binge eating disorder tend to be of normal or higher than above average weight. But it can also be diagnosed at any weight. So what do you think are some of the risk factors associated with eating disorders? So it is a combination of nature and nurture, or environmental and genetic factors. So for example, being an adolescent or a young adult female tend to have higher risk of developing eating disorders, especially for anorexia and bulimia. And the most common age of onset is between 12 and 25. And although it is much more common in females, 10% of cases detected are in males as well. An eating disorder is a disorder where genetic components appear to have a significant influence. So there is the genetic influence, especially in eating disorder. And also remember that eating disorders are not a lifestyle choice. They are actually biological influence illnesses which would often need professional help to treat. Next disorder we will discuss is schizophrenia, which is characterized by highly disordered thought processes and may be referred to as psychotic because they are so far removed from reality, meaning that an individual may experience hallucination, have delusional or paranoid thoughts. And because of this, treatment for schizophrenia typically involves more than psychotherapy and would often be prescribed antipsychotic drugs. And in addition, another method called transcranial magnetic stimulation, or TMS, has been investigated more frequently, and study has actually shown that it was successful in alleviating symptoms of schizophrenia. And I will post a video about schizophrenia and TMS in the description page, so you can check that out. So there are different symptoms of schizophrenia, and we can categorize them into what is called positive and negative symptoms. Positive symptoms is a distortion or an excess of normal functions. So for example, hearing things we cannot hear, seeing things we cannot see, and having delusional and paranoid thinking are all things that are excess of normal functions. Negative symptoms, on the other hand, are loss or decrease of normal functions. Examples are poor attention, flat affect, and poor speech production. These examples again indicate the loss or decrease in attention, affect, or speech production. Another category of psychological disorder is personality disorders. Personality disorder is a chronic, maladaptive, cognitive behavior patterns that are integrated into an individual's personality. So a person with a personality disorder may have trouble perceiving and relating to situations and people. And this often causes problems in relationships, social activities, work, or school. And because the maladaptive behaviors are integrated into one's personality, they could be very challenging to treat. The last topic we discuss is suicide. Unfortunately, suicide is not uncommon, where it is the 10th highest cause of death in the U.S., third leading cause of death among children between 10 and 14, and among emerging adults, they are 3 times more likely to commit suicide compared to adolescents. So these statistics raise an importance for all of us to know what we could do when someone is thinking about suicide. But before that, I want to briefly discuss about the myth surrounding suicide. So there are many myths about suicide. Myth number 1. Confronting a person about suicide will only make them angry and increase the risk of suicide. Fact is that asking someone directly about suicidal intent lowers anxiety, opens up communication, and lowers the risk of an impulsive act. Myth number 2. Only experts can prevent suicide. Suicide prevention is everybody's business, and anyone can help prevent the tragedy of suicide. Myth number 3. Those who talk about suicide don't do it. Fact is that people who talk about suicide may try or even complete an act of self-destruction. So now, let's discuss what we could do. So even if you are not sure if an individual are thinking about suicide, if you detect any signs that are out of their everyday characteristics, you can still check in by asking direct questions, like, are you thinking about harming yourself? It is important to be mindful of the slightest change. If you notice your friends, family members, or anyone close to you who look different, check in. And we do not want to ask like, you aren't thinking of hurting yourself, are you? Because that implies that you do not want to talk about it. We want to be a good listener and be supportive throughout this process. And even if they said yes, we don't want to react with disapproval and provide false reassurances. Like saying, oh, everything will be alright, or you should be thankful of X, Y, and Z. This is really not the time to make any judgments by sharing your opinions. This is a time for them. And if they have actual means and intent of committing suicide, this is tapping into a situation that they need a professional help. So, encourage them to seek help. If you think they need immediate assistance, you can call 911. Or you could also reach out to campus security or go to the nearest ER or the local healthcare provider. So hopefully these information are helpful. And that is all I got for Chapter 12, Psychological Disorders. If you have any questions, let me know. And thanks and take care.